Uh, Good evening, everybody, and welcome to our instruction course of Key to Setting Up an Operation Theatre, Current Concepts and Safe Practices. This course will have 5 topics covering different aspects of our operating rooms. And at the end of this IC, the topics discussed will not only help you in setting up an OT, but also help in establishing guidelines for OT environment preparation and etiquettes, which can be easily followed. For the first presentation, I invite Dr. Supriya Singh. Her topic is Design and Layout of the Operation Theatre. Supriya, you can share your screen and start the presentation.
Thank you, ma'am. Ma'am, you have to stop sharing your screen. Good afternoon, everyone. Thank you, AIOS, for giving me this opportunity. There are multiple ways to build an OT complex, but the essential principles that should be followed in planning the physical layout of OT complex are exclusion of contamination with proper traffic patterns and separation of clean from the contaminated areas. So the first and foremost thing to consider is the type of construction. Are we going to renovate an already existing space, or are we going to construct a totally new building altogether? Is it going to be an exclusively eye hospital or part of a multi-speciality hospital? The next thing to consider is the size of practice, as it is directly correlated with the number of OTs requirement and with the requirement of the space. Designing an OT complex is not merely a simple civil engineering work, but it is a combo effort of all the departments. So make a core design team comprising of senior nurses, electricians, plumber, administrators, builders, and of course the surgeon. Try to visit as many theatres as possible to understand what works and what does not work and to gain from their experience. OR has to be located on the upper levels and in the inner part of the facility to prevent dust exposure. Set aside a budget and decide its upper and lower limit. Planning has to be done depending upon the availability of funds and space. Decide in the initial part only whether you would be offering GA or not, as extra space is required to keep the anesthesia machine, and additional design is needed for appropriate plugs, suction and oxygen outlet system. Use the space as best as possible and try to avoid wastage of the space. Use materials which are easily available, durable and easy to maintain. An OT complex comprises of surgeon's room, patient preparation room, corridors, sterilization area, storage area, scrub room, and most essentially the theatre. All these areas are divided into zones. So what are zones? Zones are areas of cleanliness in which bacteriological count decreases from outer to inner zone. Zoning is important to maintain unidirectional flow of movement. There are no hard and fast rules as to how much space is devoted for each zone, and this can be done depending upon the individual setup. Always plan for separate entry and exit points for patients as well as for staff and doctors, and there should not be any toilets inside the clean areas. Ideally, operation theatre should be square in shape and should have an area of 6 to 6.5 meters square. 3.5 meters of height is sufficient for normal OT, but a height of more than 4.25 meters is needed for convenience of setting of Laminar plana. Those should be at least 1.2 to 1.5 meters wide for easy patient movement. Better to have doors of PUF sandwiched with stainless steel or HPL material. Those should be fitted ideally with vision panels to prevent disturbance and staff movement. Ideally to have electrically operated, hermetically sealed doors to ensure better asepsis. Sliding doors are always better than swinging doors, as it saves space as well as it prevents air turbulence. Walls should be smooth, non-reflective, non-porous and easy to clean. In modular OTs, walls are made up of stainless steel or EGP panels. For this, initially a framework is laid down which comprises of either brick wall or a steel framework, and upon that framework on either side PUF sandwiched stainless steel panels are placed. These panels are then painted with antibacterial paint. Paint should preferably be of light color. If Budget is a constraint that instead of stainless steel, tiles can also be used, but the grouting in tiles can become dirty, and therefore tiles and grout should be cleaned daily. And if there is a gap, it should be sealed and waterproof immediately. Flooring must be essentially slip resistant, smooth, easy to clean, and impervious with minimum joints. It should be either mosaic with copper plates to carry away any static electricity produced, or it can be made anti-static with PVC roll or epoxy. Once again, if there is a financial constraint, then instead of these materials, ceramic tiles can be used. In modular rotis, false ceiling can be made up of stainless steel or EPG panels backed with calcium or gypsum silicate. But if budget is an issue, then instead of that, plain calcium boards or gypsum boards can be used, and these should be coated with antibacterial paint. The height of the false ceiling should be at least 3 meters from finished floor level, and the color of false ceiling should preferably be white. Corners of the room should always be poked to prevent dust accumulation. Scrubbing area should be located immediately outside each operation theatre. Flooring in this area should essentially be non-slippery. Taps should be either foot pedal operated or elbow operated or infrared sensor operated. CSSD should be fitted with requisite plumbing for supply of RO water of 15 ppm. The most careful CSSDs are divided into 3 areas: decontamination area, sterilization workroom, and sterile storage zone. Decontamination is the area where primary cleaning of instruments is done, and this area should always have a negative air pressure so that air does not rush out into the other spaces when the doors are open. A simple way to achieve this is by use of a powerful exhaust fan. Sterilization zone is the one where final packing and sterilization of the instruments is done. It should have positive air pressure. Sterile storage area lies just adjacent to the sterilization zone, and this area is used mainly for storage of sterile packs and other articles. These are the parameters which must be maintained in CSSD. There should be a provision for storeroom for storing intraocular lenses, less frequently used instruments, spare instruments, scrub braces, and spare gowns. Ideally, the cupboard should be made up of stainless steel and shelves should be made up of glass inside the wall. But if this arrangement is not feasible, then the extra shelves can be made from either slated metal or terrazzo. These shelves should start at least about 30 centimeters from ceiling and should finish about 20 centimeters from the floor to prevent dust from accumulating on these items. Good lighting is needed in operation theatre. Light should always be flush to the ceiling, and the position of operating table must be decided before placing the socket so that the equipment can be plugged into the hole and can also reach the table simultaneously. Make sure there are no cables lying on the floor to avoid tripping. Use double sockets with proper earthing fuse box. Always keep a provision of generator in case of power failure, and where power failure is a frequent phenomenon, then it is worthwhile to attach the machinery to the UPS. Always try not to use the extension cables. Oxygen and nitrous oxide cylinders must be placed in a separate room with easy access, and fire extinguishers should be placed at strategic points. Clean filtered water can be used for cleaning instruments as well as for scrubbing of hands, while ordinary tap water can be used for cleaning OR. There should be a separate overhead tank for operation theatre which should be cleaned periodically. Now coming on to the most vital aspect of any operation theatre, that is air ventilation system or AHU. The purpose of AHU is to control the temperature, pressure and humidity as well as to dilute airborne bacterial contamination. HVAC system with AHU has become the gold standard now and is a talking point of all the CMEs right now. What is this HVAC? It consists of the AHU of HVAC comprises of 3 chambers. So the first chamber has provision for fresh air inlet and return air inlet. In the first chamber, these 2 airs are mixed and then it passes through a set of 5 microns filter into the second chamber, where it is cooled, compressed and then goes to the third chamber via a set of 3 microns filter. From the third chamber, air then goes to the Laminar air flow plenum, where a terminal 0.3 microns filter are placed and then comes to the OR. So this is how it looks. This is a photograph of Laminar airflow plenum. As per CBC and NABH guidelines, a temperature of 21 plus minus 3 degrees centigrade, humidity of 20% to 60%, positive pressure of 2.5 pascals, with minimum of 20 air exchanges per hour is a must, including 4 fresh air exchanges. So what is this so unique about this HVAC system? AHU's HVAC system is both an air purification and air filtration unit, as well as there is provision for fresh air entry, which is very, very important for decreasing the microbiological load. And it is not possible in window ACs and split ACs, as these are purely air recirculating units and harbor convenient pockets for bacteria and fungus, which cannot be cleaned. To summarize, designing an OT complex seems to be a tough task, but it can be made easy by proper planning and by utilizing sources in a channeled way. Thank you so much.
Please stop sharing your screen. Yeah.
Thank you so much, Doctor. May I request? Ma'am, please call for the next speaker.
Shailaja, unmute.
Thank you, Supriya, for finishing on time. Next speaker is Dr. Shogatopal. His topic is OT environment preparation, cleaning and fumigation. You can now share your screen.
Thank you, Shailaja, for inviting me for this IC, and thank you, AIOS, for giving me this opportunity. I'll be speaking on OT environmental preparation, cleaning and fumigation. So why we are talking about this? It has been shown that surgical site infection is the second most commonest cause of hospital-acquired infection, and it can lead to considerable amount of morbidity and mortality. SSI can be endogenous from the patient's own flora, or can be exogenous from the surgical personnel, from the operating room environment, including the air itself and the tools and instrument being used. Hence, maintaining the sterile environment in the operation theater can cut off a huge portion of the SSI. The basic principle is cleaning, and disinfection and sterilization. Both are important because cleaning removes the contaminant and dust and organic matter, whereas disinfection reduces the number of microbes. Disinfection in the OT actually involves 3 levels of disinfection: high, intermediate, and low. And high level of disinfectants kill all organisms except high level of bacterial spores and prions, and is effective against the sterilants, effective with sterilants such as glutaraldehyde-based bacillocid. Now, cleaning and disinfection of the new OT is very, very important, and any OT after civil work is being done. So next few seconds, I'll be talking on that. First, ensure all civil work is being completed and ensure all the movable equipment has been shifted out and is cleaned outside the OT. Then wipe all the surface of the OT and all fixed equipments like OT lamp using liberal amount of soap and water, and repeat wiping until no dust is visible. This actually, this mechanical wiping actually is very important to remove the spores and improve the action of the disinfectant subsequently. Once this is clean, you have to wipe all the surfaces again with high level of disinfectant, and then move the clean equipment inside the OT. Then you have to wipe the OT again with the high level disinfectant, and then the OT is ready to be fogging. So I'll be discussing fogging later on if the time permits. And once the fogging is completed, the sampling of the swab sampling has to be taken. The person who is taking the swab should be in OT dress, cap and mask, and use sterile gloves when performing the sampling. Only the person taking the sample should enter the OT. OT sample, swab sample should be taken from the OT table upper surface, OT table lower surface, from the floor, from the wall, from the air conditioning, from the air maintainer. And after the sampling, it should be closed till next day. Next day, the process of cleaning should be repeated again, and then the swab should be repeated again. And the same things goes on the third consecutive day. And then when the report comes back, OT is ready to be used if there is no growth being shown, or if there is sparse growth of commensal is being shown. In case of spore-bearing organisms, then you have to disinfect the OT and fog the OT again and sample it once again. If the results are not satisfactory, you have to take help of the infection control team. The roof of the OT is not needed to be regularly cleaned. Don't disturb it unnecessarily until and unless any remodeling is being done or any good amount of dust is being accumulated. Whereas the floor need cleaning regularly because 1% of the microbes present on the floor are pathogenic. Simple disinfectant can clear 80% of the flora, whereas detergent can clear 80% of the flora, whereas the addition of disinfectant can clean it 95%. Remember to use wet mop rather than dry broom, because dry broom can increase the bacterial flora in the environment. It is also very important how we are doing the day-to-day cleaning. The first cleaning is done before the OT, then OT has to be cleaned in between cases and at the end of the day. First cleaning we should be performed every day, even if the OT is not being used, and the surgeon and anesthetist shouldn't enter the OT before the cleaning is complete. And all horizontal surfaces should be cleaned with white wiping and the high-level disinfectant. And then color-coded waste bags are placed in the waste bin, and the OT should be kept closed with the ventilation equipment on before it's ready for being used. In between procedure is the neglected element in ophthalmic surgery or ophthalmic OT, but with the COVID pandemic, this has to give an equal importance. We have to look for any soiling and clean and wipe the operation table, the theater equipments, and with the help of the detergent. And also spillage of blood has to be taken care of, and any biohazard has to be discarded. And damp mopping of the floor about 3 to 4 meters around the OT table has to be taken care of. And at the end of the day, again, it should be the OT should be cleaned thoroughly, and the OT table has to be moved, and the undersurface has to be cleaned with the help of high-level disinfectant like bacillocid. The cleaning, there are a few principles should be maintained. It should be one direction clean, and either clockwise or anti-clockwise. It should be from high level to lower surfaces, so that anything dislodged from the higher surfaces is cleaned when the lower surface is being cleaned. And from it should be moved from the more clean area to more dirtier area. And if we are cleaning surface, we should clean the back surface from to the front surface or the furthest a portion of the surface first, and then the closest portion of the surface next. In India, we have extreme situations where OT facilities varying from window air conditioning or even fan to high sophisticated laminar flow system. And disinfection of the OT has two categories. One is disinfection of the OT with HVAC system, as Dr. Shupti has spoken, and in disinfection of the OT without HVAC system. Disinfection of the OT with HVAC system doesn't need fumigation. Most of the international council doesn't recommend fumigation actually, and it recommends the heat ventilation air conditioning system, which I've called HVAC system, because it gives a lot of advantage, like maintaining the air temperature and humidity, control the odor, removing of the contaminated air, and minimizing the risk of transmission of the airborne diseases. And it can give rise to maintaining of asepsis and infection control if it is used with air handling system and additional use of HEPA filters. Disinfection of the OT, as I've said, fogging is not required if we are using HVAC system, but we have to make sure that the ventilation system design is appropriate and the system performance is validated during the installation, and at least once a year, and all the parameters in every validation testing should be within the permissible limit. And maintenance of the ventilation system and AHU should be done at least once a year. HEPA filters should be changed according to the manufacturer's recommendation, and also depending upon the result of the validation test. And weekly air count monitoring using the settle plates or air sampler should be done, and the result should be within the acceptable limit. And all the staff should be aware of the cleaning protocol, because in a HVAC system, cleaning is very, very important. So all the staff should know what they are doing, and adequate time should be given for cleaning. Now, coming to fumigation, we can trace back to Joseph Lister, who used aerosolized carbolic acid back in 19th century. But and still today, formaldehyde vapor, which is produced from formalin, is used, which actually alkalizes the amino acid and sulfhydryl group of the protein and purine bases. And in spite is being hazardous because it's cheap, it's being used in a lot of places. we have to calculate the amount of formaldehyde used. There are two methods. One is electric boiler fumigation, where for 1000 cubic feet of OT, 500 ml of 40% formalin is used in 1000 ml of water in electric boiler, which is switched on for 45 minutes. And the other is potassium permanganate method, where for 1000 cubic feet, 450 gram of potassium permanganate is used with 500 ml of formalin and is left for 48 hours. Additional of ammonia is required for residual formaldehyde gases to be neutralized. Precaution should be taken because formaldehyde is formalin is carcinogenic, so gradually is being replaced with aldehyde-based products containing glutaraldehyde and chemically bound formaldehyde, such as bacillocid, as I've mentioned. Advantage, it has deep penetrating capability and no resistance strain, and effective against all sort of organisms. And after fogging, air sampling should be done. Now, for fogging, we have to keep all the OT doors and windows closed and the ventilation closed. All the instruments should be covered properly, especially the electronic device should be switched off. And in our OT, we use bacillocid, where 20 ml of bacillocid is mixed with 2 liters of distilled water, and place the fogger in one corner, directed the nozzle 45 degrees to the opposite corner. Nowadays, we can get 360-degree fogger, which moves around to use the fogging. After fogging, we should inspect if there is any wet patch in the OT, so that if there is any wet patches, we have to keep the OT closed for 2 more minutes. Just 1 second, I'll finish.
And sir, you can take 1 minute, don't worry.
We can check the OT flooring for wet surfaces. If there is excessive stickiness, we have to either check for the proper dilution is being used, or we can reduce the fogging time. These are the commonly used disinfectant. Because lack of time, I'm not going in details with this. And these are the normal frequency how we clean our OT, like roof every 3 months, was daily, twice daily, and floor twice daily. Thank you for the patience hearing, and thank you, AIOS, for giving me this opportunity. Thank you.
Thank you, Dr. Paul.
I had to rush with my presentation. I don't know whether I was audible or not. Thank you.
Thank you.
Please call the next speaker for the lack of time.
Yes, I am.
Okay.
I am the next speaker. So my topic today is patient preparation etiquettes. Etiquettes or protocols are very important for a good outcome for any surgery. So now with this COVID-19, these protocols have become important, not only to protect the patients, but also ourselves. So I have a quick question for all of you. What road would you like to take while going to your hospital? Obviously, the second one, where everything is streamlined, people are obeying the traffic rules. Similarly, if we have etiquettes, the whole experience becomes enjoyable for a patient and the doctor. So etiquettes are a set of rules that control accepted behavior in particular social groups or situations. Etiquettes increase efficiency. They help in achieving excellence and safety in patient care, reduces the chances of error, optimizes resource utilization, thereby making our surgery safer, and we get happier patients. So patient preparation etiquettes involve a stepwise approach, and it is very important that all our staff from reception, OPD, counselors, nursing staff, and the doctors are sensitized to this. Now that we are all reopening our ORs in the current scenario of COVID, hand hygiene, wearing of mask, and physical distancing are emphasized during each interaction with the patient. During counseling, the patients are encouraged to bring one attendant with them on the day of the surgery. They are asked to bathe, shave, and wear clean clothes on the day of surgery. The counselors call up the patients scheduled for surgery a day before, inquiring about history of fever, sore throat, or any other complaints. And they also encourage them to be on time to minimize the waiting time in the hospital. So on the day of the surgery, a thermal screening and hand wash is mandatory. A mask is important for everybody. The patients are given a self-declaration COVID form, which the patient and the attendant has to fill. Identification of the patient is the first most important step during the whole process. You need to correctly identify the patient, verify the address, check with the face photo on the case file. There are these identification tags available, which you can put on the wrist of the patients. If suppose you're planning for a right eye surgery and this tag is to be put on the right hand, so from a distance also you can understand which eye is to be operated. So, before admitting the patient, check whether the advice has been given, check for the eye. You need to look for allergy. A very important point often forgotten is what language does the patient understand? Is there a hearing impairment? Is there a speech disability? All these things need to be noted and addressed accordingly. Informed consent need to be signed from the patient and even from the doctor. The doctor has to sign the consent form. Check all the investigations relating to any systemic and the ocular tests are all there and placed in the file. Since most of the patients are elderly patients, doing a pre-anesthetic checkup or a medical fitness will help. Checking for gait, stability, any deformity, and thereby arranging for a wheelchair or trolley for the patients to be shifted, or any positioning changes inside the OR which needs to be informed. All these need to be noted. Very often, most of our patients are anxious patients. So spending a moment, taking some time, talking to the patient, alleviating their fear, so that would make the surgery easier and comfortable. Other people who have medical comorbidities, they need to be seen by an anesthetist or a physician, whoever is available inside the OR. In the preparation area, all the jewelry, watches, and spectacles, other belongings, they need to be handed over to the attendant. The hair of, particularly of the female patients, they need to be plaited and tucked into the cap properly. If a patient wearing a hearing aid, then it's best to be avoided on the side the surgery is being done. If the patient has a beard, then cover it properly. If the patient is using false teeth, then it needs to be removed. A note needs to be made about the medications the patient is taking, whether it's systemic or ocular, and make a note of what tablets the patient has taken, document it. If it's a diabetic, has the patient taken food? Is he on insulin? Then none of us want a hypoglycemic crisis in the OD. If there is redness or discharge, even in the contralateral eye, consider postponing the surgery. If all the vitals are stable, then the patient is made to change into a clean set of OR clothes. Here now mask has become mandatory. Cap and shoe cover is given to the patient. After verifying the eye, marking of the site can be done with a marker on the forehead or with a micropotape, whichever way. If there are additional drugs to be given like mannitol, then you need to prepare a line and administer the drug before shifting the patient, and taking care that the patient has used the washroom before entering the OT. Almost all the ophthalmic surgeries need dilatation. So before we do dilatation, you need to check for allergy, check for the eye in which the surgery is advised. Look, if the patient is put up for trabeculectomy, obviously you don't want to dilate the pupils there. So a note should be clearly written and highlighted so that such mistakes are not committed by the nursing staff. A fresh drop needs to be opened every day, and each drop which is instilled in the patient's eye needs to be documented so that we don't end up over-medicating the patient. Povidone iodine 5% is very important, and that needs to be instilled at least 5 minutes before the surgery. So that should be the last drop instilled before the patient is shifted into the OR. So such type of clutter inside the OT should be avoided. Only keep consumables which are needed for that particular patient inside the OR. For children and physically and mentally challenged patients, sometimes it becomes difficult. So allowing the attendant or the mother to accompany the child, the patient to the recovery area may calm the child. For HIV or hepatitis B positive patients, proper precautions for the personnel, for instruments, and for segregation and disposal of waste are important. Sometimes we end up cancelling or rescheduling a surgery. Here, you need to stop, for a moment, talk to the patient, counsel them, and that would make it more easier. So once the patient enters the OT, there's something called the surgical safety checklist, which is done to ensure correct procedure in the correct eye. So the check is done at 3 points, that is before induction of anesthesia, or before a local anesthetic is admitted, which is known as sign in, or before the incision, which is called the timeout, and then again before the patient leaves the OR, which is called the sign out. So this is the surgical safety checklist which we follow. This has the patient's name, the details, what kind of lenses, the packages. They give a clue to what lenses will use. It even has details of the other eye, and there are certain specific instructions also, if you want. Okay, that this is put to the attached to the microscope there. So at the end of the surgery, this paper is removed, put back in the file, and the surgical safety checklist of the next patient is put there. So the surgeon and the assisting nurse can clearly see. So before you sign in or administer the anesthesia, it's again important to verify the name, eye, check for allergy, see that the pulse oximeter is attached, cardiac monitors are attached, crash cart is there in case of an adverse event, check for the date of expiry of the drugs, clean the area properly, and at the end, remember to remove the dispose of the needles and syringes. So once then the OR sister, she paints the area, drapes, and after the surgery is complete, once the patient comes into the recovery area, any special instructions of the surgeon, it's to be noted and explained to the patient in the language they understand. The post-operative advice should be written legibly, and you should avoid using certain short forms like BID, TID, or E/D. So all these you should write it clearly 2 times a day. The instructions have to be specific. In the discharge certificate, you also have to give a number where the patient can call in case of emergency. So despite all the precautions, deviations or accidents happen. So encourage the staff to report the deviations, create culture of no blame, have an incident reporting form, do a root cause analysis, and institute measures for prevention wherever needed. So this whole thing is a teamwork, and having protocols in place will make things easier for us and surgery safer. Thank you. Yeah, I now invite Dr. Anshuman Goswami.
Thank you, Shailaja. I hope you guys can hear me.
Yes, this topic is.
Yeah, we'll just share the screen. Is it sharing?
Yes, it's sharing. Go to slideshow, please.
Thank you, Dr. Shailaja and AIOS for giving me this opportunity to speak in this instruction course on Operation Theatre. And I would be speaking about instrument preparation. So this would include basically newly set up operation theaters, as well as where you have a continuous circulation of instruments from one case to another. So I would be speaking in terms of patients or surgeries which are being in continuous use. So I'm very thankful to the institutions and places where I've worked and learned a lot from them. I have no financial interest otherwise. So we all learn surgery. That's a very good thing, but we tend to forget a very basic thing, that is like cleaning and sterilization of instruments, which we should also know. And in knowing so, we should be able to supervise our staff and workers when we are going to look after their sterilization and cleaning processes. So I would be speaking about cleaning and packaging. The rest of it, the sterilization, would be spoken by Dr. Bhaskar after this. So why do we really need to clean the instruments? We are already, sterilizing the instruments, so that should kill all the microorganisms. But the fact is that before you do that, it's very important to clean the instruments, because there are a lot of material like lens matter, viscoelastics, which remain in the instrument stuck on. And if you don't remove them, not only can they cause phenomena like TARS, but they can actually impede in the sterilization process from reaching the surface of the instrument. In addition, long-term, dirting of these instruments can lead to staining, pitting, and which may become permanent, and the instruments may get spoiled too. So, as I said, TAS is a very important factor, that because of which we have to do cleaning of the instruments before they go in for the sterilization. In fact, it's been shown that built up OVD is one of the major causes for TAS to happen. So when do we start cleaning? The most important time to start cleaning is at the OT table itself, because the moment you're carrying out the surgery and viscoelastic or blood is getting stained onto the instrument, they need to be removed as fast as possible by our assistant. By doing that, you prevent it from sticking on and it becomes easier to clean later on. So it's always better if we have a very dedicated staff, and with every passing case, the instruments are taken out and cleaned in the cleaning area, because the moment you have the instrument out of the area and cleaned, you can remove the viscoelastic blood, solid material that are stuck onto the instruments, and the cleaning is much more efficient and effective. The other thing that's important is segregation of unsterile instruments. Once the instruments have come out from the OT, the ones, for instance, which are used in DCR surgery, where it's a very septic kind of situation, should be put in a special enzymatic cleaner so that all the soil material should be removed. Those which are used for cataract and all that can be kept as a separate. Those for sharp instruments like VLANs and keratones, which are to be disposed of, should be disposed of carefully without causing any needle stick injury to the staff that is cleaning it. And disposable instruments again need to be disposed of, taking care of the environment and the other factors around us. Now there are a lot of cleaning sterilization solutions and available in the market, but what we are going to deal with while doing the cleaning part is basically like a surfactant based solution like Blanazol Pure, which is also used for cleaning other instruments like endoscopes and all that, which are basically to remove the organic matter, the soiling on the instruments. But if you are using to clean something like a DCR instrument where there's a lot of septic material and a lot of blood and tissue may be there, we might have to use enzymatic detergents like Sidazyme, which is basically cetirizine, which helps in cleaning the surface of the instrument of all the organic material, dead tissue, etc. Now, the important thing to understand is cleaning solutions should be always of low foaming in nature, should be easily rinsable or biodegradable. They should not cause any abrasion to the instruments. They should not disperse, they should be able to disperse the organic soiling properly, and they should not be toxic to the environment. So considering this, you cannot use any solution that is available in the market, and there are specific solutions like, I have no financial interest in this, but there are certain solutions which are used specifically for this purpose. Now, once the instruments are taken out of the OT, the first thing that has to be done is they have to be cleaned with the help of a brush. A soft brush needs to be a very soft brush. Please do not use the regular brush because the instruments will otherwise get spoiled. And they have to be properly rinsed in water, preferably deionized water. But deionized water can be used at the next step also. So in the first step, you may just wash it perfectly, but subsequently you have to clean it up with deionized water before you can take it up for sterilization. All instruments which have joints or are assembled should be deassembled before putting them for autoclaving, because you just have to remember this: if the manufacturer didn't manufacture it that way, it's not supposed to be sterilized that way. For hollow instruments, this is again a very big challenge, because hollow instruments you cannot clean from inside with any kind of brushes or anything like that. So these instruments you have to clean with the help of fluid only. And what we do, for instance, for in the case of phaco machine, we use again deionized water, take it in a syringe, put it through the irrigation as well as the aspiration port one after another, and flush the fluid out completely. This way it's possible to completely remove the lens matter which may be stuck in the aspiration tubing or any salt deposits in the irrigation tubing. Now you can see we are using betadine in the bowl because we don't want splashing. All these videos that I'm showing were done in the pre-COVID days, so you may not find them wearing PPE, but at present all cleaning staff should wear PPE while doing the cleaning process. And for the instruments like tubings, we use reusable instruments, but disposable instruments, but then sometimes you use reusable tubings. One can attach the infusion and aspiration port together and run the machine with distilled water or deionized water from one end, and evacuate the whole tubing of the previous lying residual fluid and the air. One important thing to understand is whenever we are using reusable tubing, please do not use it beyond maybe 1 or 2 cases, because the chance of having a group infection or endophthalmitis in a group increases if you are, say, one of the tubings is infected and it gets transmitted to the next patients. So wherever possible, at least change the tubings after every 2 cases. Now here is how ultrasonic cleaning is done. This is again a very important step, because nowadays most of the OTs should have this, because it really helps in cleaning out all the tissue material that is stuck onto instruments. You can use Blanizol or any other detergent which is acceptable for the purpose. Once the machine is switched on, you will see the bubbling inside, which actually mixes the solution. And as you can see, it's not a very foaming solution. It's a very simple solution, so that there's no overflow of the material. The instruments are then soaked in it, and as per the instructions given in the instruction manual or in the ultrasonographic cleaner, you should clean it as per the instruction given. It's usually 3 minutes. And once the instruments are clean, they should again be washed in deionized water at the end of it, because you want to remove all the leftover surfactant on the surface of the instruments. In the meanwhile, the instrument trays are cleaned and wiped properly. Wiping is extremely important, because otherwise the instruments tend to develop rusting very fast after sterilization. So once the instruments are taken out from a clean deionized water bath, they are then again wiped and arranged. You can use a hair dryer also instead of wiping. Some people prefer that. If you're using a cloth, it should be a flannel free cloth which doesn't release tissue, doesn't release the cloth from it. And you should always ensure that you put a marker, which will be discussed in the next talk. And the instruments are put in a side. Larger instruments, of course, can be cleaned using a simple water from a deionized source and wiped separately like this. A few words about packaging, because before the instruments are taken up for sterilization, packaging is the most important part. We can package the instruments either in rigid containers, just like I showed you previously, or we can use peel pouches, or we can use wrappers. Now, the important thing to understand in all this is that the packaging material, the instrument which is sterilized in the packaging material, and the sterilization technique should all be compatible and validated. You cannot mix up, a particular type of packing material and use it in a steam sterilizer, which is not allowed, and so on and so forth. And another thing that you all must follow is the manufacturer's recommendation. So here is how instruments are being packed in instrument sets. There should be enough space between the instruments to allow the steam to move out properly. I'll just finish. And there are these pouches which are available. And this is a machine which can be used to seal the pouches. And of course, last but not the least, we can also wrap it up with special tissue which is available, which is porous and allows steam to percolate through. Thank you very much. Thank you for your patient hearing.
Thank you, Dr. Goswami. Our next topic is sterilization techniques and quality indicators. I now invite Dr. Bhaskar Rai Chaudhary to make the presentation.
Thank you, Shailaja, for inviting me. And I think I have got 10 minutes to complete, so I will jump right into the topic. Can you all hear me and see my slides?
Yes, we can all hear you.
Okay. So just a few basic terminologies to start with, and that is cleaning, disinfection, and sterilization. Cleaning is the physical removal of organic soiling material and is a prerequisite for disinfection, as I'll be talking later in the duration of this talk, that deionization and removal of organic soil is very, very important for the sterilization process to be effective. And it can be done, as Anshuman showed, using water with or without detergents and ultrasonic cleaners. Sterilization versus disinfection. We hear a lot of disinfection nowadays in COVID times, but sterilization means removal of all microbial, means bacteria, fungus, viruses, parasites, everything, including spores. Whereas disinfection usually eliminates majority of pathogenic organisms, but does not remove spores. So that is an important distinction. And we will be talking only about sterilization in this talk. So why is cleaning important? As I said, that the materials of the instruments, if they are covered with dirt, then the effectiveness of sterilization process will be low. Okay, so we have different levels of disinfectants, as Shogato was saying, high level, intermediate level, and low level. As Shogato has covered it, I will not be covering it again. But high level disinfectants are the ones that are commonly used in the OT, and they kill all organisms except bacterial spores. And the classes of disinfectants, alcohol is the lowest class of disinfectant and is active against bacteria mostly and some viruses and fungi, whereas higher ones like oxidizing agents like hypochlorite, H2O2 and quaternary ammonium compounds are effective against most classes of viruses and fungi as well as bacteria. Of these, now for fumigation and cleaning purposes, quaternary ammonium compound is the one that is most preferred. Is a very old classification which has stood the test of time, a classification of equipment into critical, semi-critical and non-critical. So critical instruments are the ones that enter the secluded zones of the body. So most of the instruments that we will be dealing with in ophthalmology are critical instruments because they break the corneal barrier and enter the anterior chamber or the posterior segment. So sterilization is not sterilization only. Sterilization has sterilization, storage and monitoring, and I'll be talking about all of these separately. The most common sterilization techniques that we see are high temperature and pressure, that is autoclave and flash autoclave. Chemical sterilizers which work in moderate temperatures and moderate pressures is ETO, and low pressure temperature sterilizers which is H2O2 and or cold plasma. We will be covering autoclave and ETO in this talk because plasma is not widely used in our country. So these are the important steps of sterilization, and each step is important, particularly drying and inspection of the instrument. It is not enough to have sterile instruments. You also need to have working instruments and non-damaged instruments. So there are two basic types of sterilizers or autoclaves. One is the gravity-dependent autoclave, which is the vertical autoclaves that you see, in which the steam is let in through the sides and the bottom part, and as it floats up, it pushes the air out. However, gravity-dependent autoclaves have a problem that they do not drive air out of the luminous instruments, that is instruments with lumen, most notably tubes. High-speed pre-vacuum sterilizer has a pre-vacuum stage in which it drives out all the air, sucks out all the air by creating a vacuum, so that when the steam is let in, it goes inside the luminous instruments easily. And these usually have two settings, either 30 minutes at 121 degrees centigrade or 4 minutes at 132 degrees centigrade. So as such, high-speed, good quality sterilizers do not take more time than a flash autoclave, which we will be talking next. So the next classification of autoclave is according to class N or normal autoclave. Class S is in between N and B, and class B is the one that is supposed to be used in ophthalmology or medical setups. And these have a pre-vacuum and completely removes air from the chamber. So we will be talking mostly with reference to class B autoclaves only. Now we have flash autoclave, which is for sterilization of instruments in between cases, and it works at 132 degrees for 3 minutes at 27 to 30 pounds of pressure. But remember that this is a gravity dependent sterilizer. There is no pre-vacuum. So if you are using this to clean autoclave handpieces and tubings in between surgeries, only the outer surface will be properly sterilized. The lumen may not be taking in steam in adequate pressure and temperature. And also the flash autoclaves are to be used without the instruments being wrapped, so directly on the tray. The packaging consists of cleaning, drying, and inspecting, and then they must be packaged. They can be placed either in rigid containers, and the arrangement of instruments, the hinge instruments have to be opened out. Items with removable parts have to be disassembled. Devices with concave surfaces like bowls, they have to be placed with the concave surface down so that water does not accumulate in it. So if you have a concave scissor, it has to be put with the convex surface up, concave surface down, so that water doesn't accumulate. And of course, heavy items should be positioned away from delicate items so that the latter do not get damaged. Rigid containers are allowed. It's not that rigid containers are not allowed. According to the CDC document, rigid containers like drums are allowed, but this kind of drums, you have to be careful that when you are putting the drum in, you open the air ports, otherwise it will not work. And when you have taken it out, you have to close the lock to close the air ports so that outside air does not enter. We can also use peel open pouches, which may come in separate packages or in rolls, and we can use a sealing machine with that. Packaging material you have already covered by Youngchuman to a large extent, so I will just skip over it for the interest of time. Now, ideally, all instruments should be double wrapped and separately double wrapped. So first you wrap once and then you take another wrap and wrap it twice, not both wrapped twice simultaneously. Loading process must actually allow, the only common sense that has to be applied is that there must be adequate space so that steam can percolate. So this is a wrong way of putting the loading. This is the correct way. So small items should be placed in wire baskets or perforated trays as is shown in the left of your pictures, and peel packs should be placed on edge vertically so that one flat surface is not in contact with the tray. Storage has to be far enough from the floor, ceiling, and outside walls, and it has to allow adequate air circulation and cleaning and compliance with local fire things like it should not be within 1.5 feet of sprinklers. It should not be stored under sinks because any sterile item that becomes wet is considered to be contaminated and should not be used without re-sterilizing. Cabinets for storage can be either closed or open. There is no dictum against either, and any package that has dropped to the floor must be inspected for damage to the packaging and contents if the items are breakable before reuse. Now, this is very important slide. According to studies quoted by CDC, there is no evidence to suggest that really a date of expiry exists for packaged sterile items. So if it's stored in covered containers and package is not opened or damaged, there is literature evidence that there is no contamination for up to 2 years. But the dictum that most places follow is that 24 to 48 hours after autoclaving in double wrap we use, and for the others it is somewhere 3 months, somewhere 6 months, somewhere 1 year. For ETO it is 1 year. Now, monitoring of sterilization will be by either mechanical, that is pressure gauges, which I will not cover, or with chemical and biological indicators, which I will cover, which is most important. And the purpose is to evaluate the sterilizing conditions and indirectly evaluate the microbiological status of the processed item. You cannot directly evaluate the microbiological status of a sterilized instrument. So for indicators, there are class 1 to class 6 indicators, of which we commonly use class 1 and class 2 and class 5 and class 6. So what are these? Class 1 indicators are process indicators, which means that the pack has been placed in the sterilizer and you have switched the sterilizer on. So heat has reached the package. So this is a process indicator and it must be used in every pack. Bowie-Dick indicator is a class 2 indicator, which is a vacuum indicator and useful in autoclaves with pre-vacuum. And it only shows that you have properly the pre-vacuum part is working properly, and there is a challenge test in which you have to place it within a set of towels and look at the result. So this must be done about once a month, or if you suspect the autoclave is malfunctioning. The integrating indicator or the chemical indicator is a pass-fail indicator, which checks both temperature and pressure. And biological indicators, so integrating chemical indicators should be used in every run of the autoclave. Biological indicators or BI indicators contain a type of bacillus which is damaged, spores which are damaged by heat and steam, and these have to be tested. Depends either once a week or once a month, or whenever a new autoclave is installed or whenever it is repaired. So for ETO, the indicators are different, and there are different sets of indicators for the H2O2 plasma, etc., which we are not going to discuss. The ETO is commonly a mixture of ETO with CFC or CO2. Nowadays, CO2 is preferred because CFC is ozone depleting gas and is discouraged for environmental reasons. And this is ideal for sharps and reused single-use devices and lumen instruments. Environmental damage, and it is also hazardous to staff. So it has to be used with care. So ETO comes in these cartridges, which have to be placed inside the chamber, and the machine has to be turned on. Nowadays, most ETOs are automatic, so they give a record of the temperature and pressure, temperature and humidity, and time of the ETO.
Sir, I request you to kindly conclude.
Yeah, I'm concluding. Dry heat sterilization is in the form of hot air oven, which is not much in practice because it is time consuming, and H2O2 and plasma also is there, but not very commonly used. So just 2 more slides on formalin, because some people still use formalin. Formalin is now discontinued. If you are using it, please discontinue, because it is toxic, irritant, mutagenic, carcinogenic, and it is difficult to ensure the concentration of formalin in the chamber, and it is difficult to monitor because indicators are not available. So formaldehyde vapor cabinets or use of formalin in for OT fumigation should be discontinued, because the microbial quality of this procedure is not known, and formaldehyde vapor is very much damaging for the staff. So whatever I have said has basis in this document, which you can find open source at the given link below. Thank you.
A very big thank you to all my co-instructors for finishing on time. We were given a marathon, told to run a marathon, and had to do a 100-meter dash, literally. Thank you.
Thank you, Shailaja, for your invitation to participate in this lovely IC. Hope this.
Thank you very much, Shalja.
Yes.
For those who are watching.
I hope it will be useful to a lot of other people who are watching it.
Thanks.